With the permission of the chair, the first lecture, this is on evolving role of stem cell therapy in cardiovascular disease and peripheral vascular disease. I'd like to invite Dr. Rakesh Sharma, Clinical Professor of Cardiology and Chief of Medicine, Director, Chest Pain Center, and Co-Director, Cardiac Cath Labs at the Heart and Vascular Institute of South Arkansas Community Health Systems at El Dorado, Arkansas, United States of America. Professor Sharma, please. Thank you.
I'd like to thank the organizing committee for the invitation. I hope you guys are not hypoglycemic. I will make it a very short and sweet presentation. But I tell you, this is a very, very appropriate topic for this kind of conference. Right now it may look like very forward kind of topic, but I think the stem cells may be a treatment for a lot of problems we talked about here, which we don't have a treatment. And for example, the vascular dementia was one of the issues. So I'm going to make a case. I'm going to give a 2 decades of journey, 20 years of experience, and I'm going to sum it up in about 10 minutes. That's the plan. All right, here is a article which Dr. Reddy was my supervising author. We wrote and published. If you're really interested, look at Google us and read this article. It will tell you all you need to know about understanding the stem cell therapy in the cardiovascular disease. We all know that we have talked about preventive cardiology here. Acute myocardial infarction happens. That is going to lead to necrosis. That is going to lead to the myocardial muscle damage. That's going to lead to CHF. It is a chronic problem. And therefore, we have a lot of treatments which we're not going to talk about. But we need to come up with something which is going to be above and beyond, above that. I will cite few statistics. National Heart, Lung and Blood Institute reported a 49% reduction in age-adjusted mortality from coronary heart disease between 1950 and 1998. Well, one of the major contributing factors was dramatic reduction in the coronary events before our coronary care units and our interventional therapies, especially the STEMI programs. And even the mortality has gone further down. Well, you got to think about if we're doing such a good job in managing patients with acute myocardial infarction, what is going to happen? We're going to have a lot of patients who are going to survive that. Therefore, the survivor cohort is increasing population. Therefore, there would be increasing burden of congestive heart failure. Well, so there is a potential value. We've got to think about something else. And here we're going to talk about stem cell therapy, which may help down the line. I believe in 10 years from now, we will have a solid evidence. We will be talking it as a preventive strategy. If I can find a perfect stem cell and I can let it roam through your body and it find where the problem is, whether it's vascular dementia or a cardiac problem or something else, maybe it will help. But we got to look at the solid scientific data to really answer that question. Now this is Dr. Thompson. I tell you this first time in November 8th, 1998, I believe. That's when Dr. Thompson isolated an embryonic stem cell. But this one, look at that. Since then, he's been a most influential guy. It's been published back and forth. Look at the Condoleezza Rice way in the corner. Stem cell topic has been very well debated, very controversial over the past 2 decades. But before I talk about the rest of the presentation, I want you to get a little handle on this terminology, what we're going to use. Embryonic stem cell, what is induced pluripotent stem cell, mesenchymal stem cells, bone marrow mononuclear stem cell, adult stem cell, allogeneic stem cells, cardiospheres, cardiac stem cells. Well, I will try to shed a light in about the next 5-10 minutes. Hopefully by the time I finish, you will know it all. Now, I told you Dr. Thompson was the one who isolated, and if you look at right here, we basically all are formed from 2 cells. One came from the father, one came from the mother. Once it formed into 5 or 10 cells, it made a blastocyst. Blastocyst is the earliest form of the embryo. And that's where Dr. Thompson had extracted those cells, and those were the embryonic stem cells. But remember, there's a lot of legal, ethical issues. Therefore, we had to think about something else rather than taking the embryos and use those stem cells. Well, that brings back to us what is induced pluripotent stem cells. If I take some of your cells, for example, even skin cell, and I use a cocktail of some transcription factors and change into your stem cell, behaves like a stem cell which can work on your heart, work on everywhere else, that is induced pluripotent stem cells. Actually, Dr. Thompson and his partner was able to come up with in 2008, and actually they won the Nobel Prize for that. Of course, it's still in evolution. Mesenchymal stem cell, just keep in your mind, this is one of the cells which typically is isolated from the stroma or the tissue and the organs, more accurately called stromal cells. And the first mesenchymal stem cell was from the bone marrow. Adult stem cells, for example, all of us have some adult stem cells, not much. When you are born, when your umbilical cord has the best number of stem cells. If you would have extracted some of that and frozen, maybe this time you can inject and maybe hopefully have the benefit of that. We all have adult stem cells. They come from the host. Of course, there's no rejection. Most commonly used stem cells are autologous, which is mostly will come from the bone marrow. Now what's happening is, as in allogenic stem cells, those are the cells which we can actually get from the young donors. For example, people aged 20. If you can take their bone marrow and isolate those stem cells and put it on the shelf. In fact, I'm involved personally in 2 trials, and we have already, I will share one trial with you very quickly. And those cells may have a promise, but the verdict is not in yet. I'm going to show you real quick the ways of injecting these stem cells. You can inject in the IV, you can go ahead and inject straight into the myocardium, or you can go just like do the heart catheterization, or we do the angioplasty, go do the, put the catheter in there and inject a large number of stem cells. The problem is the retention. This is the trial I am currently doing at my institute, where what I do is when I've done angioplasty and put in a stent, I will have a balloon and the needle will come out of the balloon, and you basically injecting the cell into the adventitia. The bottom line is we really don't know what is the best delivery system, but there's a lot of trials which are done, and they all actually confuses us. I'm going to share only 2 or 3 trials with you guys, the human trials. There won't be enough time. In fact, almost would be a symposium to share those trials. But I want to share a few trials to make my point. Here are the human trials. They mostly have used autologous cells, allogenic mesenchymal cells, or bone marrow-derived mononuclear cells, or cardiospheres, which are taken just from the myocardial biopsy and then cultured and re-injected. Let's look at these 3 trials. There was one trial, Focus CCTRN, which is Cardiovascular Cell Therapy Research Network. The CCTRN trial, which was a transendocardial delivery of autologous bone marrow cells. We delivered 100 million cells in a randomized fashion in 92 patients at 6 months. However, no significant impact was noted on the primary endpoint. An exploratory analysis was done. Maybe it sounds statistically significant benefit, but those were the subgroups. Another trial, this is a Caduceus trial. Basically, it's a prospective randomized trial. What they did was they basically took the myocardial biopsies when they have done the bypass surgery, cultured those and re-injected that. And my point I'm trying to make is, even though I'm talking about stem cell, these are entirely different kind of studies. So you really can't make a conclusion. For example, this trial, Scipio. Here was another open label phase 1 trial. When the patient had a bypass, they did a right atrial biopsy, took those tissues, cultured those and re-injected it. But these trials are very different. They are not very uniform design. That's where the limitations are. We don't have a standardized stratification scheme. For example, the age or the severity of the left ventricle dysfunction. So we need to look forward what we can do. I will tell you another example. For example, there was analysis of 133 reports. There was 49 trials, but 133 reports. There were more than 600 discrepancies there. I won't list it all those. Criteria, sample size, cell count, numbers of patients, calculations. So all these things kind of led us into the wrong direction. There was a contradictory results in the same identical sample. Even though I kind of pictured that, sort of almost 15 years of experience, all I'm telling you is that trials were not designed right. However, we need to look in the future. We need to look at some meta-analysis. What can we do? So much work has been done. What would be, which will make a difference in preventing cardiology problems? Going forward, for example, there's a trial called BAMI. It's a effect of intracoronary infusion of bone marrow-derived mononuclear cells on all-cause mortality. This is a phase 3 trial. What is important is we have learned from previous experience. We've done all the mistakes, but in this case, there would be intracoronary infusion of autologous bone marrow cells, but it would be structured properly trial. They would be already looking, there would be pre-specified endpoint. It will teach us what we're talking about, is it going to make an impact or not. So after all these 7 minutes of conversation, the question is, so what? Well, you sounded very excited, but you look very pessimistic now. So the question is, the glass half full or half empty? I tend to think it is half full, and I will make that point in the next 2 minutes. Why is that? Well, establishment of safety with intracoronary delivery. I just told you the trials have been started as early as 2001. In 2001, an AMI patient was treated with by injection of autologous bone marrow cells. We have a large clinical experience to date with cell therapy with extraordinary safety. The lack of excessive arrhythmia was a very positive thing. So I think we have established there's a safety of intracoronary delivery. So if the trial is done right, if the results come, they will teach us well. Another concept, for example, therapeutic regeneration. Remember I mentioned that Caduceus trial. On the basis of this, we know that there was some growth of the tissue, of heart tissue. That kind of supports the concept of therapeutic regeneration. This is really important, allogeneic cell therapy. If we can have stem cells from young adults, like 20-year-old, and if you can culture and put it on the shelf, and that's what we're using right now in our trial, and use an appropriate person, and maybe we'll find one day a perfect stem cell which actually will work and treat those diseases. This is off-the-shelf cell products. And the trials are, of course, ongoing in many different ways. So maybe there's a hope of clinical efficacy. Multiple trials, for example, repair, acute MI trial I mentioned, clinical outcome trends in favor of bone marrow nuclear cells, and meta-analysis, I'm going to mention one which includes repair, acute MI, FINSOL, recent trial. These are so many trials. These are all intracoronary trials, and at least it's showing the trend in the favorable direction. The only problem is these trials had a different kind of clinical designs, different kind of cells, different kind of cultures, so therefore you can't really compare apples and oranges. Same thing in the heart failure patients. We have tons of database. This is one of the meta-analysis which was based on electronic database. All the databases are listed here. And the study shows that autologous cell therapy may be beneficial. So I will sum up with the 2 slides here. I think there's a lot more to come. I think in 10 years we'll be talking more. We hopefully will have a perfect stem cell which would be roaming around in our body and treating a lot of stuff. But the canonical mechanism of stem cell is the following. Number 1, it causes engrafting, proliferation, differentiating, repopulating the injured heart. And despite the poor retention of these cells, when these cells go there, it also causes some secretion of paracrine factors which may modulate further, improve the endothelial function and so forth. And next one is my last slide. The beneficial effects of transplanted cells are mostly indirect, and these come from the paracrine functions. Whatever the mediator turns out to be, there has been a major conceptual shift from stem cell-based mechanism to the notion that most clinically applied cell works indirectly, and that opens clearly a new avenues for a preventive cardiology. Hopefully in 5 to 10 years we'll be talking about that. Thank you for your attention.
Thank you, Professor Sharma. Please stay on. We'll take up the discussion at the end of the next presentation for a combined talk. Please have your seat.